Start with the anatomy. For Achilles tendon rupture, the important structures are gastrocnemius, soleus, Achilles tendon, watershed zone, calcaneus insertion, and sural nerve region. Do not memorize the picture as a list. Ask what each structure is trying to do when the person moves. In real life, the problem sounds like this: a sudden pop, heel pain, difficulty walking, and inability to rise on the toes. That story is the doorway into the diagnosis. It tells us which tissues are likely overloaded, irritated, torn, compressed, or failing to share load. The core mechanism is sudden eccentric calf load, tendon degeneration, gap formation, loss of plantar flexion, and rehab protection. This is why two people with similar images can feel very different. Tissue appearance, load, inflammation, nerves, strength, and confidence all interact. For the lay viewer, the question is not, what word is on the scan? The better question is, what system is failing? For the resident, the question is sharper. What is the pain generator, what is the structural risk, and what can safely wait? A practical way to think about almost every orthopedic problem is tissue capacity versus load demand. If the load is temporarily too high, the answer may be calming and rebuilding. If the structure has mechanically failed, the answer may need repair, reconstruction, replacement, or protection. The common symptoms cluster around pop or snap, posterior ankle pain, weak push-off, difficulty single heel rise. Symptoms matter most when they form a pattern. One symptom by itself can mislead. A cluster is much more useful. Listen for timing, load, swelling, night pain, mechanical symptoms, and whether the person is losing trust in the limb. Also listen for what the problem has taken away: sleep, walking, work, sport, independence, or confidence. The best history is not a questionnaire. It is a map of what loads reproduce the problem, what settles it, and what function is disappearing. The exam should not be random. For this topic, deliberately check palpable gap, Thompson test, resting ankle angle, neurovascular screen. A good exam separates pain from weakness, stiffness from fear, and joint disease from referred pain. For patients, the important idea is that touching one sore spot is not the same as understanding the whole problem. For residents, every test should answer a question that changes management. If a test is painful but does not change your plan, it is theater, not medicine. Good examination is selective and